we got a quorum. Okay. All right. Good afternoon, everyone. I call this meeting of the Health and the Public and Community Health Committee. Speaker comes and walk. We call it one way. I call it the other way on the wording. But anyway, okay. One of the first things we need to do for the committee, Representative Tyler Paul Smith has asked that we hold his bill until tomorrow. So we will be doing that. We will be meeting again tomorrow. I think it's at 3, so stay tuned, and I'll tell everybody, and we'll send out a notice by email, because I've forgotten what room it is and the exact time. We seem to be playing fruit basket turnover as it goes with the rules. Okay, and let's go first. Representative Stevens, since I just had you up, if you'd like to present House Bill 557, and then everybody make sure you have the right LC. It's 339429.
Yes. Thank you, Madam Chairman, members of committee. House Bill 557 is a PA and APRN prescribing bill that will streamline some of the actions and clogging, if you will, by the Composite Medical Board. This bill will allow PAs and APRNs to prescribe on a short course of medication, 5 days of C2s, modeled after South Carolina. It seeks to streamline some of the procedures and requirements for the Composite Medical Board. Schedule 2s, as we talk about Schedule 2s, the APRNs in Georgia and Oklahoma are the only states that prohibit APRNs from any sort of Schedule 2 prescribing. However, Oklahoma does allow their CRNAs to administer C2s. Physician assistants in Georgia and Kentucky are the only 2 states that have a blanket prohibition on controlled substances, specifically C2s. Texas allows for hospice and hospital use only, and Hawaii only allows for inpatients. In many practices, there's only a PA and an APR or an APRN in their practice, specifically when it comes to health care in some of our rural areas. I'll try to speak more into the microphone. The Composite Medical Board has some challenges. We've heard from APRNs waiting for as long as 6 months for their approval of their APRN job description. That's a problem. We must remove or at least minimize some of the superfluous requirements by the Composite Medical Board that will not harm patient safety, because given the state of the workforce delays in licensing and approval, the job description of APRNs and their protocols is to reduce the healthcare workforce, massive healthcare workforce shortage that we've got to see in patients. In 2022, the annual report for the Composite Medical Board showed initial licensure applications were up from 4,418 in 2018 to 6,948 in 2022. However, the percentage of licenses approved or denied within this 90 days is down from 85% in 2019, 90% in 2020 and 2021, but down to 75% in 2022. We must clear these clogs or budget the work of increase in residencies or loan repayment programs, or all the things that we're doing in the appropriations process to get this worked out. From the Governor's Healthcare Workforce Commission, and I quote, "Our recommendations are focused on strategies that will maximize our existing workforce and to optimize the education system and attract new workers." How can the workforce be maximized when the education system be maximized if we cannot attract new healthcare workers when we do not have the licensing system that meets the needs of the clinicians in the healthcare facilities? The first 3 paragraphs, 1, 2, and 3, are taken directly from the final report of the Healthcare Workforce Commission. Note the language suggestions. Let me move on to the bill itself, Madam Chairman. Section 2, lines 34 through 36 removes the prohibition of APRNs prescribing Schedule IIs if authorized by protocol agreement. Lines 37 allows APRNs who are at least 1 year post-licensure, they've already been out practicing for a year, with clinical experience to prescribe an emergency 5 days Scheduled IIs, assuming the doctor has approved the APRN to write these scripts in the job description. Line 41 through 54, the APRN may only provide these prescriptions if it specifically includes the protocol agreement, meaning the docs have approved the APRNs to do this in the first place. The APRN has directly evaluated the patient, and that means direct contact with the patient. Is limited to the initial dose of 5 days and 5 days only. If it's for patients under 18, and this is where we'll talk in just a moment, if the patients are under 18, the only medications allowed are hydrocodone medications or medications to treat ADD. And I'll ask you to go back and amend that at the end of my presentation here. Lines 53, the APRN must complete at least 1 hour of continuing education biennially for any Schedule II, and that would be for the stimulants and also for hydrocodone compound products. Most of the rest of the strikeouts remunerated are related to drafting to take into account the rest. Lines 80 through 90. Here we seek to streamline some of the functions of the Georgia Composite Medical Board. As a background, the APRNs are licensed by the Medical Board of Nursing. However, to write prescriptions for Schedule 3, 4, and 5, they must be licensed, must have a Composite Medical Board approved nurse protocol agreement. That's a mouthful. In other words, they're licensed by the nursing board, but to write these prescription drugs, they have to get that from the Composite Medical Board. That's okay. There is an incredible backlog of these protocol agreements under the Composite Medical Board, 6 months. In this section, we're seeking to streamline the process for the healthcare practices that already have an approved nurse protocol agreement. Lines 80 through 84, the section provides that if the practice is adding or changing or delegating a physician, and the protocol agreement will be substantially similar. Lines 85 through 90, the section provides that a physician who is adding, changing, or changing a PA to the same practice terms, etc., for the previously approved nurse protocol agreement. The new agreement or additional agreements still have to be filed by the to the board, but it will be deemed approved. Section 3 talks about the physician's assistants. This portion of the bill does all of the aforementioned things of the APRNs for the PAs. In other words, as a background for the PA licensed by the Composite Medical Board, physicians are licensed, of course, by the Composite Medical Board. However, for a PA to do the work, the job description between the PA and the MD must be approved at an individual level by the Composite Medical Board. Ladies and gentlemen, that essentially is the bill. This is to streamline the process to get more and more folks, patients seen by APRN. They must be out in the workforce for a year, both for nurses and for the PAs. That's what it does, and I'll take any questions you might have. But before I go there, I would like to point out on page 3, lines 45, once you have all of your questions, I would ask the committee to strike on lines 45, beginning with the word unless authorized by the delegating physician to order hydrocodone compounds, and then the word or. So let me read you how it would read if we struck this. The prescription drug order for the individual 18 years or older, medication to treat the attention deficit hyperactivity disorder or individuals under 18 years of old, so long as the delegating physician is a pediatrician, family practice physician, internal medicine physician, or psychiatrist. What this does is it disallows APRNs to write hydrocodone products for those patients under 18 years of age. But however, it still allows them to write for stimulants. That's the bill in a nutshell, Madam Chairman, and I'll take any questions.
Are those lines repeated for the PAs somewhere in the bill?
They are repeated, yes.
Well, where do we need to strike those? It should be from schedule to concern to emergency situation.
136, yes, 135 and 136.
Okay. Also, one of the things that we had talked about, and I don't see it anywhere, in approving all these agreements and protocols, there's no thing in this that says they need to be in good standing.
I have no objection, of course, to that one. That's understood.
Okay, well, right, but,
I don't think they'll be able to have a license if they're,
well, sometimes it takes the board a long time but an automatic okay and transfer, that's
in good
immediate.
standing. I have no objection.
Can you tell us where we would put that, and is in good standing, the places for, you don't have to do it right now, we'll get you in a minute.
Sure.
But saying that they have to be in good standing in both, does that cover it as far as being specific enough?
Yeah, Madam Chair, we can get the best language for that, but I would assume somewhere like line 37 and
I mean, I just don't want it to be that they'd say, oh, we're in good standing because the nursing board hadn't reprimanded us yet.
yeah,
Or the medical board hadn't reprimanded a PA.
right.
Something that covered that there are no complaints or,
Yeah,
I know.
It would say something like in advance practice, registered nurse in good standing with the board who is at least 1 year post licensure, et cetera. So that's like line 37, and then the same mirrored language.
yeah, but then, okay. Right,
Sorry.
all right. I was in good standing or doesn't have any pending complaints or something, think about it for a minute. Okay. All right, questions from the committee. Representative Al.
Thank you, Madam Chair, and thank you, Chairman Stevens, for bringing this. I enjoy working with you, and I know we work in a lot of similar spaces, you being a pharmacologist and me being an anesthesiologist, which is sort of what's driving this question. I appreciate your points about the workforce shortage in Georgia, particularly for medical practitioners. That is a really important issue. But just putting that to the side for a second, my concern with this bill and the version of the bill that we saw last year is that in my professional experience in working very closely, particularly with Schedule II narcotics, that I work very closely with morphine, fentanyl, Dilaudid, all these types of medications, is I think the last thing we need in the state at this moment is more people being able to prescribe opioids, right? I think that we've seen with respect to the opioid epidemic in the past decade or so, that often what has sparked, the nidus for this epidemic taking hold is a readiness to write for even a short course of pain medications. And I think the studies have shown that even a 5-day course, as you've described, of parenteral opioids increases the risk of addiction up to a year out from that short course, which is often prescribed after surgery or some sort of procedure. That's the first thing. And just looking at the most recent stats in Georgia, which has continue to increase in our overdose deaths, that the deaths in Georgia have increased by about 62% in the past 3 years of all drug overdoses. So I will tell you, as someone who takes care of patients, and I get this, the easiest thing in the world to do sometimes is just to write a prescription because it makes the patient happy and they're asking for it, but it doesn't ultimately serve them that good. So increasing the interface by which patients can get Schedule II narcotics is problematic for me. So I wonder how you
That's
how you
a very
view
good
through
question.
that lens of increasing that interface and making it that more people are able to write these prescriptions.
Let me tell you the way that it used to be done, and this is, not very long ago. If there was a problem with writing, once upon a time, to get a prescription, you had to have a prescription pad, and of course we had scenarios where nurses would tear off the pads and sign it, and we would not know that a physician didn't sign that particular prescription. They would show up. That's not the case today. Today, you and other prescribers, including PAs and APRNs that are attached to a physician, they have NPI numbers. So before, whenever there was a problem with these things, the only way we would find out is if somebody said, I think this nurse may have stolen a prescription pad. So then the Drugs and Narcotic Agency would come in and look through our files and then go to every other store, and you can imagine the delays that we would have. It could be months before we actually could trace down the source, if you will. And now, today, it's almost instantaneous because as an APRN or a PA, if they write a prescription under a physician, we have to input both of those NPI numbers for the prescribing physician and the nurse practitioner or the PA. So that information is almost instantaneous, and it's hard for somebody to abuse that privilege, if you will. That is kind of set off. And again, I'll remind you on the amendment that I'm asking that any patient that's below the age of 18, that they not be allowed to prescribe hydrocodone products. And if it is only a 5-day supply, then we're looking at sometimes a holiday forward and backwards, a Friday and a Monday. I've seen those scenarios where it has helped the physician, if you will. And as far as the stimulants go, that's probably where I see most of the problem, where moms are just ADD as well as the child, and they forget and run out of the medication, and there's time to go to school on Monday, and there's no one that except for a PA or an APRN to do that. But I think because of the safeguards and the immediacy of the transmittals, that we will catch these bad actors and also the drug seekers, because keep in mind, whenever we fill for a patient, we know now with our system that a pharmacy can get online real fast and see if there's a drug seeker that's showing up in your pharmacy. In fact, we have to check it. So that system has been set in as well. So I think there's enough safeguards placed there to keep these drug seekers from getting there.
About illicit diversion of people, like in the olden days, stealing a triplicate prescription pad and these types of things. I'm not so much talking about that, and I'm not even so much talking about people who are seeking to who are drug seekers, as you say, that we've seen people go medication shopping and go from ER to ER. That's not what I'm talking about. What I'm talking about is that there has culturally been in medicine, and we're trying to undo this actively, that it is very easy to write people for opioid medications, right? It's the easiest thing in the world to write a script for someone and give it to them. And what we found over time, and this fortunately has hit some of the lay press now that there's mini-series and books and so forth about it, that we actually seeded our own problem in our readiness to get those opioid prescriptions out, that we are creating an environment where it's very easy for patients to become addicted through no fault of their own, because they're being given the prescription, they're being told that this is right for them, right? And I think that takes a lot of active untraining within the medical community. Remember when pain was like the 5th vital sign, and we were all exhorted to treat it when I was in med school, that if a patient had a pain scale of above a certain amount, we were instructed to write them for opioids, and we realized that this was that we dug ourselves in a hole and we were hurting a lot of patients. So my concern is that by increasing that interface and bringing in people who haven't been habitually, first of all, trained medically to look for alternate non-opioid-based pain medication solutions, and who need to, frankly, move the mail of the patients, that it's going to be very easy for this huge influx of prescription writers to flood patients with opioids, which is not necessarily going to help the problems that we're seeing right now. So that's just my point.
And point well taken, and I'll just respond in this way. There's only 2 states now that don't allow these APRNs and these nurse practitioners and the PAs to write for these drugs at the arm's length with the protocol. But I do agree that opioids are a problem.
Sorry. Representative Silcox.
Thank you, Madam Chair. And Mr. Chairman, I appreciate you bringing the bill, and I certainly appreciate the workforce concerns. And I guess speaking from my viewpoint, since my husband is a physician, before he can write before he does write a prescription for opioids, he generally wants to see the patient in person, because a lot of times people run out of their medication over the weekends. And so I guess as a safeguard, would it be possible to add that this APRN or PA see the person in person to verify that this is something that's really needed?
It's in there.
It's in there. Okay, I apologize. And second, with regard to the job description, is there a place where the job description has to be? That's just, I know you're looking for a good requirement to see that they have at least 1 year, but I'm just wondering where that would be.
That again is going to come from the Composite Medical Board.
Okay.
And different than the nursing board, the Composite Medical Board is going to have to verify that.
Okay. Okay, thank you.
Representative Dempsey.
Yes, thank you, Madam Chairman, and Mr. Chairman as well, too. I just had one question. When you were talking about striking the language, then you referred to 135 through 136. It stays there. Is that correct? Or is that,
We're removing.
are we to just strike that also?
We're striking that as well.
Okay,
What we're
okay.
doing with opioids is we're
I
going to
wanted to make
say,
sure, yeah.
and that's a very good question. We need to make sure, I think, that we limit to Representative Al's point, that we limit these opioids to no more than 18 or older.
Right, okay. Great, thank you.
Given Representative Al's question, how many more people, prescribers, even on a temporary basis, will this be putting out in Georgia?
I'll have to ask some other folks here.
How many nurse practitioners will this allow to, how many?
I think there's probably some other testimony.
Well, no, I want it,
18,000.
how many?
18,000 APRNs, but they won't all be, many of them in hospitals already and have that right.
Okay, but somewhere 15, 12,000 more people prescribing just APRNs?
I think it'd be less than that, Madam Chair, because of the hospitals already doing it, it'd be less than that, much less than that. But when I get up to testify, I'll try to have those figures for you.
Okay, well, and then, we ought to include PAs. I think part of what's concerning to many of us, and to me especially, is so much of the nurse practitioners now are getting their training online instead of, more clinical, and their clinical experience is questionable. That doesn't happen in PAs or any other part of medicine. And we are having some trouble with the nursing board with some of the programs that have come across in our state. So, which I must say the nursing board hadn't done a really great job on getting them out of our state, which we need to do. They're taking clinical experience away from our students, the ones we pay for. So that is a concern of mine.
Oh, thank you, Madam Chair. So I want to, for clarification, this bill addresses nurse practitioners and PAs that are working alongside a physician.
or on a protocol, because in some areas like rural Georgia, an APRN or a PA may be the only thing there. So again, that would eliminate some of the problem, and your question's perfect, may eliminate some of the problems in rural Georgia where workforce is a real issue, and the only healthcare professional there that can write, even on a short-term basis, is going to be a PA or an APRN working on a protocol.
And further question, if a physician goes into this protocol agreement, I assume that they do that willingly and knowing to some degree that their license, and correct me if I'm wrong, is somewhat attached to the function of this PA and nurse practitioner. And I say that to say that I've certainly worked in the healthcare environment, and I watch the nurses and the PAs and the APRNs, and I don't find them to be incredibly careless, but in this conversation, we tend to always think that they are somehow going to be these wild prescribers, especially with this 5-day limit. I'm not seeing it that way, and I'm thinking that these folks have been attached to a physician, that hopefully the physician is knowledgeable and has chosen someone wisely. I think I'm missing some of the connection between the questioning from our perspective, and I think that your answers have been solid, but I just want to be clear about that. They're attached to a physician. It's a 5-day limit. They're not prescribing hydrocodone for 18 and under.
Correct.
Thank you.
Representative Lott, I think I can answer some of your questions about the concerns. They do work under a physician's protocol, just like the PAs do. But then for infractions of a protocol, the physician and the PA are, reprimanded or whatever by the medical board. But the nurses aren't. They're reprimanded if they are reprimanded by the nursing board. So they lose sort of that connection, whereas they're working directly under. And I will tell you that there is a tremendously greater percentage, and of course there are more nurses, of nurses that are addicted and have addiction problems than we find in the PAs. All right. And if you want to debate me, I'll do it later. So, okay, Representative Parker.
Thank you, Madam Chair. And over here,
There you go.
Mr. Chairman, I love your bill. I am a product of medical professionals, and but I'm just a farmer. I don't know what I'm doing here, but I love the access to health care. I happen to live in a community that does not have a physician. We do have a number of PAs and APRNs, and they're the ones that treat me when I come in scarred up and needing stitches and need help, and I am so thankful for them. That being said, opioid abuse and addiction is a real thing. We absolutely know that, but we also know that it's not caused by the physician's assistants nor the APRNs. They've not been able to write these scripts. So, I mean, right now the bad actors are not these people we're addressing in this bill. It doesn't appear to me. And I don't know if the protocols that we have, the emphasis we have, I don't think it necessarily flows that adding additional healthcare providers that can prescribe these on an emergency basis necessarily means that we're going to provoke more. I think the bad actors right now are certainly not our PAs. So,
Just to respond to that, we can continue this conversation, but this is not so much an issue, I think, and I would pose as a question, do you think this is an issue as much of access to health care generally versus the profligacy of access to opioids? I just want to tease those two things out because obviously we understand that there is a workforce issue and we want people to have access to health care. My concern is that this allows much more readiness for a vastly greater number of people to write opioid prescriptions. And as someone who has written these prescriptions, I know it's actually quite easy to do it, and it's almost becomes a reflexive thing to do, and it's not malpractice as such. I don't like talking about it in terms of people being bad actors because there's not malintent in that, right? And like I said, we were trained for decades to write opioid prescriptions, right? So I think it's not that the intent is bad or that they're bad actors, people trying to flood the market or what have you. It's that when you have many, many different interfaces to provide opioids, that it only really takes, as research has shown, even just a 5-day course to increase someone's risk of addiction for up to a year out from that initial prescription, right? So just think about how many more patients can be affected by this, and we see the results of that easiness to write opioid prescriptions to this day, right? So to go back in that direction of increasing that access is, to me, a step backwards in our understanding of how we should be handling opioid prescriptions.
Representative Perkle, I don't think we're trying to really demonize either one. It's the matter of the numbers and the fact that one of the reasons that we have seen a decrease in the number of prescriptions written is because we've ridden the physicians so hard, and with the PDM, to try to get them not to write them and so forth. And I think the concern is when you're talking about 10 or 12,000 new nurse practitioners and maybe, half of that on PAs, we have less. I think that is the concern, is just, and I will tell you that they've been able to write Schedule 3s, which, as far as not having something to control pain, they have been able to write those. So I think it's just concern about the number, and like Representative Al said, it's just more people out there that people have access to. And I think that's what it is. Representative Reese.
Thank you, Madam Chair. Mr. Chairman, I just want to say thank you for this bill. I, too, am married to a physician, and I talked to her about this, and it made her happy. Because where I'm from in Columbus, Georgia, we're there on the outer edge of the healthcare desert that we find in Southwest Georgia. And when you are looking for a healthcare professional to help you under extreme circumstances, or situations like in my wife's office where it's kind of hard to maintain physicians because they get drawn to the larger market like Atlanta, we have to think about these bills collectively and how they impact people all across the state. And when I spoke with her about this, she felt like this would give her a great relief, that this would give her some more individuals in her office that can deal with the smaller things, the emergency type situations, while she's handling greater things. And so I understand no bill that we write here under the Gold Dome will ever be perfect. The opioid epidemic is terrible. It's horrible. It's something I want to see us get control of, more control of as a state and as a country. But at the same time, we have to be able to balance that with finding progress on how we begin to remedy the lack of health care and healthcare assistance that we have in some of the extreme rural parts of our state. And I think this right here takes us, at least part of the way of dealing with that, with individuals who will be monitored. My wife has to go back and look at the notes of all of her PAs that work up under her. There is a relationship, as was mentioned earlier. There's a very strong relationship that she has to monitor carefully, because if not, then it puts her license in jeopardy. And with that said, Madam Chair, I would like to move that we adopt amendments that was placed to LC 339429. Yes, at the appropriate time.
And, and I will say, because like I said, we've ridden the physicians very hard to quit ordering so many Schedule 2s, to use 3s. And I'm glad that Representative Reese's wife oversees her, PA or nurse practitioners. But I can't say that all physicians do that, and I have ridden them about that also. If they want to complain about something, or that, that they needed to pay more attention and oversight if they're going to use extenders. So, there's room on all sides of the issue. It's just concern about the increased numbers of Schedule 2s, opioids, and Oxycontin especially, not anything else. So, okay, Representative Lott.
I just want to ask one further question. You brought this up earlier, and I just, for clarification, and I want to understand, but because we are talking about this opioid crisis, which of course we all agree exists, you brought up NPI numbers. So can you just explain one more time that what you were stating about tracking?
Yeah, absolutely. Again, before it was all paper. Everything now is has a national provider number, if you will, and that number is attached to a physician. It's attached to every PA, and it's attached to every nurse practitioner. So as they write a prescription, and especially with PAs and nurse practitioners, you have to submit both the physician that they're working under and the PA or nurse practitioner, both at the same time. Now, there are times, again, and this bill covers that if you move from one physician to another in the same practice, there's provisions in this bill for that. Or if you move to a different practice, you have to get approved again with the physician that you have the protocol with. That's covered in the bill. But you've got to transmit that, and you know immediately who the physician is that authorized the PA to write that, and you know the PA or nurse practitioner that wrote it.
Does somebody look at that information?
Yes.
So that is actually monitored. So if I were a nurse practitioner and I were regularly writing and prescribing hydrocodone, then there would be a red flag. I mean, somebody would catch that. There's a mechanism for
Yes.
viewing that.
And of course, if you're in a physician that's under a hospice physician, of course, all that stuff is taken into consideration. It goes to drugs and narcotics, and they'll come by and ask us for those orders.
Thank you. Thank you for your answer.
Are you saying, all right, is that all on one prescription, or are there nurse practitioners or PAs, if they order it, are they going to be on a separate thing? Is it going into the PDM that the nurse practitioner, Sharon Cooper or whatever, wrote it, or is it still got the physician's name attached to it?
It has to have both for to transmit that prescription. It's got to have the authorizing physician that the PA is working under, or the nurse practitioner, and the nurse practitioner. Without both of those, in other words, I can't submit a prescription with just the nurse practitioner on there. It's got to have that authorizing physician.
Awesome, PAs. Okay.
Thank you. Yes, I'm glad we're having this discussion, and I'm grateful for my colleague Representative Au's comments. This is a bill that I feel like APRNs are underutilized in Georgia, and I've had conversations with some of the physicians, and I also had a conversation with my sister, who is a nurse practitioner in Seattle. She is a pediatric oncological nurse practitioner. She specializes in solid tumors. She trained at St. Jude's. She has been published in multiple publications, and she's able to do a lot of things that she would never, frankly, be able to do here. I would love for her to move to Georgia. She will never give up the professional life that she has right now outside of Georgia. And in talking to her, I said, well, what restrictions, do you have right now with Schedule II? And there are none. It's hard to understand because they are trained in these things. What she said to me, she said, look, if the pharmacology training's all the same, what's the difference in 5 days and more than 5 days? But I do feel like I think this is a very real workforce issue. I think that the training that these APRNs get, I think we're understating it here. I mean, yeah, you can take courses online, but your practicums, your clinicals, all that's happening on site. That's not happening online. You are getting that clinical experience, and I feel like it's important that we recognize that, and that we recognize the training that these APRNs do because it is significant, it is real, and they absolutely have a daily impact. I mean, I live in Atlanta. I've got lots and lots of physicians. I have, multiple physicians that I can choose from, and even with my regular doctors, the dermatologist that I go to every 3 months for a skin check, I see the APRN or the PA. When I'm taking my kids to the pediatrician, most of the time it's the APRN who I'm seeing, and that's how healthcare has really started to work. But I do think we need to recognize the educational accomplishments and the training that these APRNs do have, because it's not just taking a course online. I think it's a lot more than that. And I do think that the workforce issue is real.
Glad your sister's so well trained, but that training and the clinical experience does not happen as apparently it has happened for your sister at Bates. There is a lack of it and a shortage of hours on it. So I'm very great. I'm sure she's great. Representative Chokus.
Madam Chair, at the appropriate time, I'd like to recommend do pass amended.
I think that's the appropriate time.
I move that this House Bill, let me see, LC 339429 amended, receive the due pass recognition.
Okay, we got a thing in a second. Huh? Yeah, we need an amendment motion right now. Okay, we need a motion on the amendments.
So moved.
Okay, we have amendment, okay, everyone in favor of the, of the amendment on striking it about hydrocodone? Is that all right?
Yes.
Hydrocodone first, because we need to do the other one. Say aye.
Aye.
Anyone opposed, no? Okay, the ayes have it, and I am appreciative of it looking out after children, since there is indications that even, one prescription increases the chance of a young person becoming and using opiates.
Thank you,
illegally
Madam
as an
Chairman and
adult.
members of the committee.
Okay, and how did we decide? Did you come up with something we could say, Betsy? Wait, it's not over.
Oh, sorry.
That was an amendment.
Well, I just thought, okay.
All right, on line 38 and 127,
38 and 127.
after the word experience, add the language and in good standing with the board.
And in good, okay. On line 38, after experience and, you would add and in good standing with the board.
That's right. On line 127.
Okay. Can I have a,
I'll make a motion.
okay, we have a motion. Do I hear a second? I hear a second. And that was on line 38. And what was the other line, Betsy?
127.
127. Okay, any discussion? Okay, everyone in favor of the motion say aye.
Aye.
Anyone opposed, no. All right, the ayes have it, the amendment stands. Okay, we're back to the bill. We have a motion and a second. Is there any further discussion from the committee? Okay, I will take, but it is now 4:30 and we need to move on. So if you're going to speak to the bill, I'll give you like about a minute. Let's see, what number is this bill? 557. Okay, Sheila Hubbardson,
I'm happy to waive off. We support the bill. Thank you.
thank you. Aubrey Valance,
I'll waive, we support the bill.
thank you. Okay, Tim Davis?
I'll waive as well. We support the bill.
Thank you very much. And that, okay, everyone in favor of House Bill 557 as amended, say aye.
Aye.
Everyone opposed, no? No? Okay, okay, we have two noes. Okay, the ayes have it, and the bill is passed. Thank you. Okay, let's do House Bill 226. This is a bill that has passed out of this committee. Okay, this is House Bill 226. What are we working on? LC 339441S. Is this a new one? Okay. Okay. All right. This, we seem to have had, this is the HIV bill. What you need? This is moving people who are HIV positive onto our, and they are eligible for Medicaid, onto our Medicaid program. There was some discussion about it because it went to 1-something%. What's the top on? One used to be 138%, poverty. This brings it back to 0 to 100% of poverty. So it lowers that. So there'll be less number of people eligible. So do and I'll take questions. Nobody has a question? Okay, do I hear a motion? Huh? Wait a minute, we have a question.
Well, no, I was just gonna, recommend a do pass.
Okay, got it. Thank you, Representative Reese. I've got a motion do pass. Do I have a second? Okay, any further discussion? Is anybody on this one? 226, no. Has anybody thought they come in since we let the sign-up sheet on this is on House Bill 226? Would like to say anything? Okay, no, then we're ready for a vote. Everyone in the favor of the substitute to House Bill 226, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. That takes care of that one. Okay. Representative Hilton. Okay. Representative Hilton is not here yet. Okay, here I go. Do you want this, Okay. Years ago, on the ambulance service, and this includes anybody that's got an ambulance. If your fire department in your area has 2 ambulances, they pay this tax. So anybody that has an ambulance, and the number of ambulances they have, we decided that ambulance providers should pay so much money per ambulance so that they could draw down a match from the federal government. That's it. However, and that money would be used then to help provide ambulance services across our state. Well, they have been paying that fee for several years, which in some cases amounts up to almost $500,000, which could be used to provide another new part of it, help supply newer ambulances, newer services to our communities. But instead, it's just been going into the general fund and hasn't been given back to the ambulance services. So basically what this does is do away with that tax. Would anybody like to speak on the bill? In case I wasn't really prepared to do this, but as a favor to Representative Hilton.
Yes, I'm Josh Mackey. I'm with the Georgia Association of EMS. We are very supportive of this bill. Happy Representative Hilton brought it. Madam Chair, I think you gave a really good explanation and overview of this bill. As you mentioned, ambulance services have paid this fee/tax for roughly 20 years without a direct return to them. It was supposed to work similar to a provider fee, or it was supposed to work as a provider fee similar to what hospitals and nursing homes have.
Right.
Never happened. It's gone to indigent care in general. So our goal with this bill is to eliminate the fee. It would help every single ambulance service not have to pay it, so they would save money going forward. Doesn't matter whether it's public, private, hospital-based. Every single ambulance service in the entire state and every county pays it. Adds up to roughly about $4 million that they're contributing each year.
So, and the hospitals have now been made whole. So the Indigent Trust Fund is not as needed as it has been in our hospitals. Both small and middle-sized and large have been made whole. So there's no excuse for having it now except it's just an excess tax. Questions for the presenter? Representative Burkle.
Thank you. So we've been collecting this tax. This is the equivalent of the bed tax, or whatever they call the bed tax, in essence, with hospitals. We're trying to trying to draw down federal funds.
Right.
So we didn't draw down any federal funds to help you?
The federal funds are drawn down, but they're paid out for indigent care in general. They're not dedicated. They don't go to ambulance services.
Okay,
like
so
those
it's just
funds
been a
for
drain
hospitals.
for ambulance services, and now we're trying to
Correct.
stop the flow.
That's it.
All right? At the appropriate time.
Okay, and if you listen to the people who do okay, here we go, and I lost the name. They come and report to us. They connect all of our services for wrecks and things across the state. They will talk about how some of the areas don't have an ambulance as it is now, or they have one, and if it's gone, it hurts with our coverage of our state for emergency situations. Am I right?
Yes.
Yes. Thank you. Okay. All right. Do we have any, did we get a motion? Yes, Teddy, okay, we have a motion to pass. Can I have a second? Okay, we have a motion and a second. Is there any further discussion from the committee? Hearing none. Is there anybody else in the audience that would like to speak to the bill? Okay, if not, it's time for a vote. Everybody in favor of House Bill 453, say aye.
Aye.
Anyone opposed? No. Okay, all right, thank you. Thank you very much. Would you let Representative Hilton know that he'll need to fill out whatever forms he needs to fill out, please? Okay, and we're holding Representative Tyler Paul's bill. And so, Representative Oliver, are you ready? Okay. And this is 520? Okay, where are we going? So if you have, wait a minute, it's substitute to House Bill 5.
LC 339452S that we had yesterday. And Chairman Jones will be with us a few minutes. He had an emergency that he had to take care of. We've already printed. I've already printed copies of all the amendments.
No, we don't have the right bill. We don't have, that's not the right number. We don't have the right number.
It's the same as yesterday's.
Right, we don't have the right. Okay, read the, Maggie.
The same, the number yesterday that we were working from is 339452S. And we are prepared to move forward with that bill with some amendments that have been discussed with a variety of folks.
Maggie's going for it. We just have to stand in.
Thank you.
Everybody, don't go away. We're going to pass out the amendments so you can start to look at the amendments.
Yeah, let me, I think.
Okay. Okay, let's get this going. Thank you to everybody on the committee. Did we keep a quorum? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There's Teddy. 11. Okay, you get the golden ring this time or something. Maybe I'll keep sweets, and the last person that gets to 11 gets it each time. Then y'all all would wait outside the door and fight over who could be 11. Okay, thank you. Can we be informal, Todd and Mary Margaret? So, anyway, okay, we are working right LC 339452S. Okay, and I have asked Todd to clear up Representative Jones since it's going out over the airways. There is one area that has been of great concern. It is Section 1, and I have asked him to explain very carefully what has happened to Section 1. And with that, you have the mic.
Thank you, Madam Chairwoman. I appreciate that. I recognize that there are people here at the committee today who were here yesterday, and then I know there are those who were unable to make it yesterday because of conflicts with other committees, and also were presenting bills. So Representative Oliver and I, here's the agenda that we'd like to take, assuming Chairwoman Cooper is fine. I'd like to first hit an overwhelming question that we've been getting about Section 1. Then want to make sure if there's any, I'll say, outstanding questions about the sub. Then go into, you should have the amendments in front of you, and then go into the amendments. So let me first start with Section 1. And if we need to, Leg Counsel Betsy Howerton is here, and she's much more learned in terms of the reasoning behind why we have to do this. But if you take a look at Section 1, please, starting effectively line 66 all the way through page 12, line 289. That statute, 177130, if you went on LexisNexis right now, it's there. And you would see it is the exact same verbiage, except if you would be so kind as to turn to page 8, starting at line, nope, not page 8, wrong one, my apologies. Page 6, starting at line 124. That subsection C has been slightly reworded from the statute that exists in law today. I'm sorry, starting on 124, Madam Chair. Okay. The changes are effectively on line 128, second word, that may formerly was a shall. Then, if you please go toward the end of line 128, where it says department, what was added was right after department, starting with if, all the way through the period on 130, which is an inpatient. The last change was made line 131, where it says accused as an outpatient, which is the first 4 words. There was about 6 words taken out if the accused is charged with a nonviolent offense. Other than that, and I believe this is case law and why we have to effectively take it out and put it back in, we effectively take up 12 pages of this bill, Section 1, for those, I'll say, add of 12 words, taking out of 6 words and the change of 1 word. So I just wanted to make sure that there isn't confusion. Now, there will be 2 amendments that affect Section 1 that will be up for your consideration. We're not getting there just yet, but I just wanted to make sure that you knew that that was in fact the reasoning, because there's been so many questions about Section 1 incompetency, how it works, why it works, and we wanted to make sure that the committee, along with the public, knows that's existing statute. That has been in there. Some of that has been in there for decades. So, Madam Chair, I'd like to pause right there before I keep going and see if there's any questions. Would that be okay?
Questions from the committee? Nobody on the committee? Okay, that got it.
All right. Madam Chair, I don't know the will of the committee, especially those that weren't here yesterday. Representative Oliver and I are prepared to take questions about 520, or should we go there, or should we start with the amendments?
Does anybody, let's go through the amendments and see if if some question you might have has been answered by the amendments, and if not, if you still have a question that wasn't touched on, is that okay? Representative Chokas, you had a question. Sorry, sir.
Yeah, Madam Chair, parliamentary inquiry. Should we make the motion and then have the amendments in the discussion, or do we talk about the amendments first?
No, we're going to vote on them individually as we go along. We probably should go ahead and make a motion on the passage of the bill.
At this time, I'd like to do that.
I got a motion to do pass. Okay, we got a second. Is there any discussion? Hearing none. Everybody that, let's see, do we vote? No, we wait and vote on that later. Got it. Okay, so we're in that position where we have a motion on the big bill with a due pass, and now we're going to go to amendments, and we'll vote on them individually at a time. Thank you. I'm just sit there. It's getting late. Okay, but don't hurry. This is too important. Okay.
Varsity on Chairwoman Cooper, given the fact she's holding us. But in all seriousness, wish the committee, could you please refer to the amendment AM 332024? This was proffered by the Sheriff's Association, and at the proper time, Madam Chairwoman, after we present, we'd like to have the Sheriff's Association come up and speak to this.
Fine.
But if I could address everyone, if you could keep your sub next to you and at the same time your amendments next to you, you will see that we are striking lines 186 through 213, and we're substituting in this language. If you're looking at your sub, I will please direct you to line 189. You will see the second to last word is return. We're striking that return all the way through line 192 of the court, comma, the department may. So that language is struck out of the sub, and what is then put in, you will see on line 6 of the amendment, toward the end, the department shall hold the accused at the department's secure facility instead of at the court's detention facilities whenever the department physician or licensed psychologist provides, et cetera, et cetera. The next part of the amendment goes down towards line 195. Oh, I'm sorry.
No, I mean, I'm confused.
Oh.
It says amend the substitute, okay, by striking lines 186 through 213.
Mm-hmm.
So we totally strike those.
Yes.
That's what I thought, but where were you talking about the end of return?
Okay, so my apologies for the confusion, everyone. The language, as you can see on line 3, lines up with 186. So line 3 of the amendment to line 186 of the sub. So you should see E if the evaluation performed.
Right.
My apologies, Madam Chairwoman. What I was trying to provide to the to the committee was where in the sub did the language change, as opposed to you guys doing like a compare and trying to figure that out. So should I maybe do that again, just for the purposes of the committee?
I think so.
Okay. So again, my apologies. Line 186 of the sub, line 3 of the amendment starts with if the evaluation performed. But I would direct you to line 6 of the amendment, which corresponds to line 189 of the sub. And you will see the language towards the end of 189 that starts with the department shall return the physical custody of the accused to a sheriff of the jurisdiction of the court, semicolon, provided, however, that as an alternative to returning the accused to the sheriff of the jurisdiction of the court, comma, the department may. Okay? Now, if you then, I hate to say it this way, but move over back to the amendment, you will see at the end of line 6 there, which again corresponds to 189 in your sub, now says the department shall hold the accused at the department's secure facility, etc. I will let the Sheriff's Association explain, but effectively, I agree with their logic. If the individual has been deemed mentally incompetent, then the best place for them, in my opinion, would be the department and not going back to the county jail, given the department is most likely more, I'll say, equipped to handle someone who's been deemed mentally incompetent than going back to the jail where we typically don't have that type of resource.
Okay, do you want questions now? We need questions now.
Do you want us to finish? Or, I
Okay, go ahead.
apologize. Should we finish the whole amendment,
Right,
Madam
finish the
Chair?
whole, yeah, finish the whole amendment.
Okay. Do you want me to keep going? Okay. If you could go to the end of 195 on the sub, we struck the word alternative, so such detention, it'll say now inside of the amendment. Okay. And then at the end of 196, we struck regardless of where the accused is held.
I think what's confusing people, and maybe it might just be me, I might not have been able to make it to medical school, Perkle. So, I don't know. It's a private thing we were discussing. And anyway, instead of just telling us, what it changed, what is totally new right now is we struck 186 to 213. So is there a need to refer back to the original, or just this is what it says now?
Okay.
Okay?
Madam Chair, just for the benefit of the folks that weren't here yesterday, the context of Section 1 is in that what we think of as the forensic section of the code, where somebody has been charged with a crime already and they've been determined to be incompetent to stand trial. So we're in that kind of weedy area about what is the accused rights if he's incompetent and where does he held. And we talked yesterday about the 641 forensic beds that are within behavioral health. So the movement between the arrest, the jail, and the forensic bed is what the context is. It's not just picking up me on the highway because I'm running out of gas and acting crazy.
But this is how we're going to deal with them now.
Yes, ma'am.
And we can pay attention just to this without going back to the,
Yes, Madam Chairwoman, I apologize. I'm not meaning to confuse anyone. If you want to, just say, yep, this is the amendment. The genesis of this is E1, and then also 2. You'll see E1 refers to misdemeanor, E2 refers to felony, but it is effectively the exact same change. Instead of that individual who's been deemed mentally incompetent being taken back to the jail, they would remain inside of the department's facilities, and that's the net of that amendment.
Yeah.
My apologies if I made it calculus instead of simple arithmetic.
you did.
Yes.
That's okay.
Okay.
Y'all know it. And we got a question. Okay. Representative Taylor.
Thank you, Madam Chair. Just a quick question. The change is that it will stay in the court's detention facility. Is it located in the courthouse, or do they have, where is it, and does every county have the facility to hold them?
It's different in the 142 jails, and that's one of the reasons that behavioral health has to really take over these forensic patients. In DeKalb County, they have a medical unit. In Gwinnett County, they have medical units in
Thomas
a
County does
gradation
not.
of way. In many counties, they don't, and that's why the forensic beds in behavioral health. The sheriffs don't want the mentally incompetent people in their jails, and so this is a transition that actually the Georgia Supreme Court has told us we need to do some of these movements.
Okay, in a rural community that does not have it, where are they to take these people to be held, whether it be a patient, or is it going to go, where do they go?
The behavioral health crisis beds is one unit, many of which are secure, not all of which are secure. Most of them are secure. So behavioral health is what the sheriff wants to deliver that person to.
Has behavioral health accepted this? Are they aware of this?
They're
And
aware
are
of-
they already accepting them?
They're aware of the case. They're aware of the context of what we're doing today. Yes, ma'am.
What are you looking at on this? You've heard, not.
Where it says, line 7 of the
Okay.
amendment, it says it'll be the court's detention facility.
All right.
And my courts don't have a detention facility in the courthouse.
But
That's, That's what I was
The
addressing.
do you have a crisis intervention?
We have one in one of my counties. The other county does not.
Instead of.
And it serves like 5 or 6 counties. We have
Do you see what I'm saying?
7 beds.
Yeah. Chairwoman Taylor, the idea is that we are requiring shall hold the accused at the department's secure facility, and the department in this case is not the court, but rather the department, the DBDHDD. So instead of at the court's detention facilities, whenever department physician, et cetera, et cetera, et cetera. So in many instances, not in many instances, we will hold them at the department's facilities. Right, instead of.
Instead of the court's
Okay.
detention facility.
Okay, so they, in our case, some of the rural communities would go to wherever they have a behavioral health facility, and they will be prepared to hold somebody. Is that correct?
Correct.
Forensic beds.
Right.
Thank you. And are these just misdemeanors? Or this would be? These are
Madam-
saying, it says charged with misdemeanors.
Correct, and if I could alert you, section 1, line 6 of the amendment is misdemeanor. If you go to line 19, number 2, that's the felony part. So the
it's-
amendment
both
covers.
of them are the same thing.
Exactly, yes, ma'am.
Okay, thank you.
All right. Any other questions about this amendment, 2024?
Chairwoman Cooper, do you need the Sheriff's Association to speak on this, or are you comfortable?
If he'd like to, I'm sure he,
On behalf of Madam Chair.
in case. Thank you.
My name is Terry Norris. I'm Executive Director of the Georgia Sheriff's Association, and we appreciate this friendly amendment. I've had the pleasure of speaking to this group, your group, many times, and we come back with the same message every time. Jails have become the quasi-mental health institutions in our state and other states throughout the country, which is wrong. In the case that we're talking about today, we're talking about an individual who has been charged with a crime, who has, for whatever reason, through their defense or whatever, has asked the court to determine whether this person is competent to stand trial. The judge orders a competency evaluation. That person goes through the forensic evaluation process through the state offered by DBHDD, and then that evaluation results comes back to the court. And in cases where individuals are deemed incompetent, and in many cases it's said likely not to be competent, those criminal cases are stayed. Those criminal cases are not active, and that person, the last place that person needs to be is in a county jail. We all have agreed to the fact that we need to do what we can, whatever we can, with the resources we have in our state, to move folks out of prisons and jails that have mental health issues. So these amendments, or this amendment, will ensure that we're not placing someone who is severely mentally ill, not capable of being processed through the court system, back in a jail cell in one of 142 county jails, many of which lack a lot of mental health services. So we applaud the effort of this amendment, and we hope you will look at it favorably.
At the appropriate time.
Okay. Any other questions for Sheriff Norris?
Thank you.
Okay. I mean, because, again, this is severely mentally ill person. Not your person that's just having a little bit of a behavioral problem. They would go back to the jail, or we're talking about a real bad case of schizophrenia or manic depressive and not capable of.
Yes, Madam Chairwoman, the individual has have already been deemed mentally incompetent.
Okay.
To your point, not to suggest bipolarism or depression or schizoaffective, et cetera, they need to be deemed mentally incompetent to stay in trial.
Oh, okay.
Yes, ma'am.
Question? Thank you. Is anybody from DBAD here, Department of Behavioral Health here to address it? Thank you. I just have a couple questions.
Sure.
Are you prepared? Do we have resources to handle these?
Good afternoon, Michael Polchek, Director of Legislative Affairs at DBHD. This is the first time this amendment was brought to our attention, so we haven't had a chance to review. I'm not prepared to speak
Okay.
to that this time, unfortunately.
Again, I'm from a rural community, and I know we have such limited resources. That is my concern. Thank you.
Oh, that was my question actually to the author, if we have considered, so, you know, do have human resources, but there's also financial resources, appropriations that should be. Is this where I think there again, I want to second Chairman Chokes's amendment on this, but has the appropriation been made, or is this something that's going forward?
Discussed yesterday, Representative Perkle, we recognize that the forensic patients within the responsibility of behavioral health is an ongoing issue, and in the bill in another part we have set up 2 mechanisms to deal with analysis of this issue. What will it cost further than the money we already expend for the 641 beds at 4 different hospitals across the state? But we're doing a bed study. Where are the beds? Do we only need forensic beds, or do we need traditional treatment beds? And another part of the bill, we've set up an analysis. Again, all of this was set up in terms of a work plan for when the governor signs the bill to December 1st to review all of our forensic statutes. And I think that the tension and the focus on that population is strong right now. And behavioral health, originally the request that we look at these forensic beds, and specifically for this determination of those who have been determined incompetent to stand trial, behavioral health has been definitely a part of that. And I have some confidence that as this work plan comes forward along with this amendment, that we can make an analysis about where the beds have to be after the bill becomes effective.
Thank you.
Thank you for those questions. They were good. I asked the same thing when they presented that to me. But it is such a problem with the level of illness in these patients that we do something. So if in your committee, as you consider the budget, can we just go ahead and ask you for more money, please? And yours, okay, yours too, please, Katie. Representative Howard, get you next.
You used the term a few minutes ago about has been deemed incompetent. Where's that timeline from the point of arrest, or how are they deemed incompetent? Or when do you make that determination?
That's a very good question, and it's very much a part of the analysis and the focus that's going on right now. Person is arrested, and they have are required to be appointed counsel. The counsel's going to make, legal counsel's going to make a determination, is this person able to participate in defending himself? That's the initial set of questions that come from lawyer for the person who is mentally ill visibly and not able to communicate. And then the judge will make a determination based on evidence presented. The prosecution and the defense may not agree. Frequently they do agree that a person's not competent to stand trial. But it's a legal proceeding set out in the statute that has to be managed and determined by a judge.
Can I follow up, Madam Chairman? So where are they held between the time of arrest and the time of that testing?
Because they have not been determined to be incompetent yet by the judge, they're going to be in the jail. And after the termination of incompetency, there's going to be the issue of if they're, where they go then.
Yeah, I did have a question because, so what is the effective date? Because this is written, you know, as shall do.
Mm-hmm.
So we're struggling for money right now. So when does this have to be effective, and when does appropriations have to have the money for it? I know where we are at this moment in time, and it's tough.
Well, you know that the fallback, the default is that all bills signed are effective but July 1st unless the bill sets otherwise. And that's what this bill would, if the governor signs it, would become effective July 1st. But as I said also yesterday, some of these work plans and analyses that we've set forth in the bill, both Justice Boggs and Kevin Tanner, Commissioner of Behavioral Health, have already anticipated, they've asked for these work plans, and they've anticipated opportunities to receive some grant monies for them.
But if it is going to be in place July 1st, in order for us to be in compliance with that, we have to have money for that, and we're way into that appropriations process right now. So I'm not trying to set up a roadblock at all. I'm trying to say, how, where do we get the money to meet this? And I'm trying to help y'all. Is there a place that language can be put in here, like pursuant to appropriations or something, so that we are not creating another obstacle that cannot be delivered?
Several places in the bill there, it does say specifically subject to appropriations.
So when we're telling the department they have to take something that the sheriffs are not, don't we need to?
Okay.
So I don't know where it would go, but I think that to make this hold up and not create a new problem, we need to, in some place, say pursuant to appropriations or whatever is appropriate language.
Betsy, could we amend the amendment to have that?
Constitutional
Because if it's going to be contingent on appropriations, then the current law would have to be restored and operational. So we could either make this whole section of the bill contingent, in which case we lose the changes that are required by the Supreme Court's decision. So,
right.
That's.
I mean, it can be done, but it would have to. We'd have to sort of, we call it double drafting. You'd have to have two provisions, and this one's effective until the other one went into effect.
And
So
then
that-
what if the department says we can't do it? What if we've just told them to do, and I'm just asking very hypothetical
So
questions.
what about, if I could direct a question to Lead Counsel?
Yes.
Lead Counsel, what if we were to, this is existing statute, could we hold the existing statute and then just say upon appropriate appropriation or whatever, however the phraseology would be, then this strikes into effect, so the current law stays the current law, and then this comes into effect upon the proper appropriation? Again, I asked that.
Yeah, we could, but again, the changes in C that you mentioned also wouldn't go into effect unless there was appropriations.
If we subjected this particular section to appropriations?
Right.
Oh,
Yeah. You don't want to do that. That's what you were saying.
no, we can't do that.
So you don't want the whole bill to be in that?
We need to change, sorry, I don't mean to be
That's
informal.
all right, go
Yeah,
ahead.
we need to change 124 through about 132 in the sub, lines 124 to 132, which this doesn't address. This was the part of the bill that we needed to change in section 1.
I just feel bad that the commissioner's not here and there's absolutely no one, there wasn't conversation with them about it. I mean, it's not
a
mine to
suggestion-
fix, I'm just
yeah.
saying that,
A suggestion Representative Oliver just proffered was we just take out section 1.
Of the bill altogether. I mean, that's y'all's call.
I mean,
Okay.
is that,
this is, so if that's what you're thinking about, Representative Oliver, could the rest of the bill possibly move forward and there be time to negotiate that part, that one, if you're going to take it out, not to make it go away, but to let it stand alone as a correction that may have to take another day, that one part?
I'll just tell you my preference, and Representative Jones will add to it and amend it. I would rather take it out than have this question unheard and allow Kevin Tanner and the sheriff's folks to talk, and we can revisit that. This was a request that came from Judge Amero, who again is in the very details of this competency statute, which is troubling a lot of different folks about
Right.
where people have to be determined on what timeline. So if it is of concern, and I believe it's concern that's reasonably stated, I don't believe it's irrational concern at all, I would personally rather take it out, and I'm happy for my partner here to disagree with me.
but what are we taking out? Are we,
All section 1, and we're not addressing any amendment that the sheriff wants.
Or there's another amendment that touches section 1, and obviously we would not amend that, or not visit that. Madam Chairwoman, I tend to concur with Representative Oliver in terms of we want to respect what the Sheriff's Association is asking for. I tend to agree with the Sheriff's Association in the sense that they're not prepared to handle this. At the same time, I think it's a fair question in terms of what the department can or cannot do. I think removing Section 1, and if there's something that we can do later on, then we will do that later on. But I think removing Section 1 keeps it clean.
Okay, can I just have assurance from both of you, because this going back and forth and I haven't, we're not losing something that you felt like we needed in.
No, ma'am, I don't think so. And
Okay.
if we are able to resolve this real question with some other voices that aren't here, we can revisit it in the Senate if there's a mood to do it over there, and we would keep the House updated if there are further discussions. That's
Okay.
my feeling today.
All right.
Yeah, I think it's good to keep the lower chamber involved.
Oh, yeah.
Oh, so when it goes over to the lower chamber, you'll take care of it?
Yes.
Okay.
So
Clue them
then-
in on what's right.
We'll make an alternative amendment if we may. I'm not making the amendment right now. I'm suggesting that what we might want to consider is to offer an alternate amendment to remove Section 1.
Okay, I think we ought to probably handle this as we go along. We've got an amendment. Have we just looking at this? We hadn't. Had you made? No, we're not. Okay, then we are.
In discussion, if I'm not mistaken.
All right, so
My question, is, and this is more to legislative council, is if we offer another amendment, approve this amendment, and then insert at another place upon appropriation of funds, so that we can satisfy the sheriff's department, and then just put in a separate section upon the appropriation of funds to satisfy everyone.
Possibly. I mean, we can renumber the amendment as on line 3 as E.1, possibly, and say we could add something at the end that says E.1 shall take effect upon appropriations, and upon that appropriations, then subsection E will stand repealed or something like that.
Madam Chair, would that be
Not-
acceptable?
I don't know. Wait a minute. Not very what, Betsy? Not very elegant. A little awkward, but you could do it. I'm going to leave it up to the authors. Which one would you prefer we do?
Take it out, ma'am.
Take the whole section 1? Okay,
I would like to remove my name as a second on that amendment.
thank you. I've got a removal. Who made the first? Okay, sure, go ahead.
Now, I don't want y'all to walk away from this concept. I also don't want the Senate to fix it. Y'all heard me say that yesterday. If it helps to move the entire rest of it, I would like to ask y'all to immediately begin working on Section 1 as its own separate measure that does come from the House, that we get the bulk of it out, but that we immediately, maybe even by tomorrow, if that can be negotiated between behavioral health and the sheriff's department, and we figure out the pathway and where the money is and what we can do, we've got plenty of time. We really do, right? There are a number of things. I mean, we do. If y'all can act quickly upon that,
Yeah, so
not
Chairman
tonight,
Dempsey, yeah,
for us to vote on it, but
What?
Yeah,
I
you
don't
just
want it
laid
to
out.
go away. I don't
Yeah,
want
so
it to
Chairman
go
Dempsey, you just laid out an option that was already running through my head. I hadn't obviously spoken to Chairman Oliver yet because it's been 30 seconds. But the idea in my brain going on, I had thrown out the lower chamber because Dr. Au was sitting right there, and I thought it's always nice to see that someone chose the right side. And but in all seriousness, I do believe one could sit on its own. Possibly, but I needed to confer with Representative Oliver, and then also with Leg Council, and then also obviously with the department, and then with Terry Norris. So we're on the same page.
Are we talking about a separate bill?
Oh, I'm sorry. Yes.
Yes,
I
and so
apologize.
just saying,
Yes.
that's
But
what
I
I
want
thought you were
it.
saying,
I
but
want
to
it
make
to
it
happen.
clear.
Okay, I mean, I want y'all to do that, Bill, like that we are chasing it with this one, is what I'm saying.
Yes,
And
ma'am.
we're having another meeting tomorrow if you can get it in and read and whatever we have to do.
Negotiate.
negotiate.
They're vehicles.
That's true, there's a vehicle, which would be better. Okay, we've got the proposed substitutes off and withdrawn. Okay, Representative Taylor.
Thank you, Madam Chair. Just to follow up, I know we're moving a lot of different directions, but this follows Representative Howard's comment. When somebody has been deemed, they're going to go to the Department of Behavioral Health. How long do they stay there? What if the court doesn't have it come up for 6 months? They can only stay there a week or 10 days or something.
There's the case of Carvey State that gave the original impetus to this discussion about a particular technicality in the outpatient, inpatient. But then there's Commissioner Tanner's greater concern, and all the criminal justice folks I talked to, greater concern about exactly what you're talking about. And that's why we have in the bill a real analysis of where we are. Are we in compliance with the statutory timelines or not? And how many forensic beds additionally do we need or not need, depending on the analysis of our bed space? So.
Well, we have, if I may go on, we have some state facilities for the forensic. Would they be removed from the county where they are and kept up there until the 6 months or 8 months until they have a court? Or would there be a place locally? Again, it's logistics, but that's just the way my mind works.
It's important logistics. There's 641 forensic beds. It's the biggest set of hospital beds that behavioral health manages.
They're pretty full. Full, aren't they? Completely full. That's what I thought.
So that was my question. Where do we keep them, and how long can you keep them? And again, this is something Department of Behavioral Health needs to get us online where we can get it handled. Thank you.
Okay, so tell me what we're doing right here.
So I would suggest
We're-
there could be a amendment made by a committee member to strip section 1, and I'm not quite sure the form of that amendment. I don't know if it would be just section 1, or do we need to say the lines?
Section 1.
Betsy.
I mean, I think it could be by striking section 1, which is lines 60 through 289, and then we'd have to delete some language out of the title on lines 2 through 5.
And as a member of the committee, ma'am, if I may, I make that motion. That
Okay.
we remove section 1 and the lines referenced by Ms. Howerton and remove it from the title section. If I may make that amendment at this time.
Right. So we're removing lines 60 through 289? And renumbering, and Betsy will, if there needs to be some words or something related to that from the,
Yeah, on lines 2 through 5, we'll take the language out that relates to that section.
in the preamble, in the title. Okay. All right, I've got a motion. Did I see a motion? Do I have a second? Okay. Any discussion? No? Okay, we're ready for a vote. Okay, on, I guess I call it Amendment 1. Everyone in favor say aye. Aye. Anyone opposed? Okay, the ayes have it. We know what we're doing now. Okay?
All right.
Next.
Thank you. If I could turn your attention to the amendment AM 332022.
Okay. Everybody got it? Little short one.
Well,
Okay, on
we would-
lines. Lines 3.
lines 1 and 2 of the amendment effectively replace the phraseology 3 or more interactions within a 6-month period with frequent contact, and that's shown in 3 places, line 388, well, old 388, 415, and 1327, basically in the printed copies. The logic behind that is there's a study that'll be going on for familiar faces, as we discussed yesterday, and the logic is to allow the study to go through and allow the cross-departmental, I'll say, function to come up with what is probably the best definition of frequent contact as opposed to put it into the statute.
Questions?
This is a matter that other states have dealt with, whether you quantify the definition of frequent contacts. And on this particular section, I believe Justice Boggs and Commissioner Tanner have discussed it.
Okay. Okay, Representative Chokas, wait just a minute. Representative Chokas. Okay, we've got an amendment and a second for the passage of AM 332022. Any further discussion?
Madam Chairwoman?
See, yes?
I didn't refer to 3, 4, and 5 yet. I just want to make
Oh,
sure
sorry.
that people have that
No.
before they vote, that's all. Okay, thank you.
I was reading it, it was one thing. Okay. And everybody who wasn't here yesterday realized that instead of calling them frequent flyers or, well, I don't know what else they've been called, we're talking about the severely mentally ill that sort of go between the criminal justice system, homelessness, and behavioral health system on, you know, a rotating basis.
Yes.
Okay, everybody in favor say aye. Aye. Anyone opposed, no. Okay, so we have the passage of AM 332022.
Which one do you want to stake on?
If I could turn the committee's attention to AM 332025. There were several stakeholders who contacted us over the last 24 hours, and there was a question that was effectively proffered around as these individuals are going into the monitoring and then into the rehab for, I'll say, maybe drug addiction, alcohol addiction, etc. The question that was proffered was, when do these individuals have the ability to come back into the workforce? And though it is statutory that they fall underneath the authorities, the idea was, could we do something to be able to provide a little bit more clarity within the statute and to be able to help our constituents and our stakeholders. So the idea here was inserting professionals on line 789 and 839 for the following. And you'll see that for the purpose of ensuring the fitness of such healthcare professional to resume or continue practice of his or her healthcare profession while maintaining the safety of the public. So essentially, the question that was proffered was, this individual has voluntarily gone in, they've been monitored, they've gone through rehab, so now the question becomes is, are they ready to either continue practice or are they ready to, quote, recommence practice? And that's what this amendment does.
Motion at the appropriate time, please. Make a motion that we do pass this amendment.
Melissa Kay, why do we, this is somebody who wants to speak to the, oh, but, okay. Okay, yes, all right. We're not to that, Rhea. Okay. Okay, fine. Okay, good. Everyone in the favor of the amendment 2025 as read, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. That one passes. Okay.
Madam Chairwoman, this is Representative Oliver and I's last amendment. We kept this one last only because we have on that, I believe it's 6, in terms of 6 changes. So we took this one thinking this would be the one that would take the most time. So the best laid plans.
Okay.
So if I could refer you to AM 332023.
On line 520. Yep.
Oh, I'm so sorry.
No. These amendments are really for the purpose of coordinating ongoing other parts of the bill and ongoing discussions in relations to a variety of things. For instance, lines 3 through 5 relate to what 1013 set up about a coordination with the newly constituted match committee. It's just an example on page 21 of those lines where we're just expanding, and so we're not duplicating some services.
I think Representative Oliver hit 3 through 5 perfectly, so I think that's great. I want to go ahead and go 7 through 10, and in 7 through 10, that is effectively, you'll see that by striking 1136 through 1138, which you'll see is effectively a bullet point. And this was a recommendation that we received, and the analysis is that this language will allow us to better serve the children's mental health needs by including family therapy codes, which end in 846 and 847. So slightly different, but there is an addition with 846 and 847 on line 9.
Previously, we weren't going to pay if the family needed therapy. Is this what this does, so that the therapy could extend to the family?
I think DCH is already paying family counselors, but this was making it more consistent in relation to a variety of different kind of providers.
Okay, got it.
1139, so after licensed professional counselors, insert right before the word in, licensed marriage and family therapist and certified peer support specialist.
Okay.
So this provides for greater alignment with Medicaid, and it also increases the pool in terms of available workforce. And
Okay.
that's something that I know has been, I'll say, a general theme of this year's session.
Should turn the light off. Terry, did,
My question was just answered.
just answered? Okay.
I want to keep going, Madam Chairwoman, unless.
Right.
Okay. Starting with line 13 of the amendment, so striking 1144 to 1148. And then inserting, and then I'll let, for the purpose of the committee, I won't read that entire section. You'll see it goes from line 14, pardon me, to line 22.
Federally qualified health.
Okay. Questions on this one?
Did you want to go? Second to the last, striking lines 1142 through 1152. 1152, and then providing for 24 through 28. And then these additions ensure that therapeutic services include foster caregivers and the family of origin where appropriate. Which there has been, again, another general theme of foster care within this year's session. And then finally, line 29, inserting on line 1161 between recipients and the period, the following, and their caregivers if the recipient is under the age of 19. And this is basically the reason or the rationale behind that is to broaden the pool to ensure coverage, especially if the recipient is of that age. And that is 2023. Did you want to add anything?
Okay.
Madam Chairwoman, I don't know if there's any questions, but that's the
Right.
end.
Are there, that's what I was getting to. Are there any questions? Representative Bell.
Sorry.
And Representative-
This is not a question, but just before we move off the amendments, two very simple amendments that relate to something that we had talked about in previous iterations related to assessing our workforce skills and deficiencies with respect to culturally competent language access. If I could suggest them, and you just see they're very easy, they don't substantively change anything, but in the original bill, of the original numbering, in line 420, that sentence ends with the word workforce. I'll let you get there. But basically, after workforce, if you would consider adding, including the availability of culturally and linguistically responsive services, and that gets after something that we've talked about since last year. And one other very small amendment, sorry. Yeah.
That's consistent with what language we put in 1013. So it updates this analysis. This is a study section about behavioral health workforce, so that's consistent with 1013.
Okay.
Yes, ma'am.
You're saying it's consistent, not duplicative. You're not saying it would be.
Exactly.
Good, okay. And then the other very small addition part is in the section that begins on line 1222 on page 48. There's a number of attributes that you wanted to survey for the healthcare professionals who are in active practice: age, race, gender, 4 is ethnicity. If you could add 5 as languages spoken, I think that would address a lot of the access issues that people are having trouble with. And then just renumber the remainder.
Tell me again, where I agree with that, where did you think that should be? What
After
line?
ethnicity, so 4 is ethnicity, maybe add 5 languages spoken, and then 6 could be location of practice, et cetera.
Those are acceptable to us, I believe.
Those are acceptable.
Sorry.
Have we approved all the amendments except this last one? Okay, Representative Lott.
I do have one question, and I apologize. So I'm coming in a little bit late on this. But on line 13 of your amendment page,
I don't think we did.
It states that we are striking lines 1144 through 1148. And I just want for clarification, on your amendment sheet, 2023, the one we were just going through, line 13 states striking 1144 through 1148. I just want to be clear, 1148 is E, reimbursement for eligible justice-involved youth ages 18 to 21 years. And I want to know, did you mean for that to be, can we make the amendment
Thank you.
to the amendment?
Yes.
I'd like to make a motion.
Thank you.
Thank you.
Great catch.
Every once in a while.
Can we do an amendment to amendment, or just take that one? Wait, it's amended.
Amended.
Okay. All right, okay, so where we stand, we okayed all the okay. Representative Perkle.
Thank you, ma'am. I promise you this will not be a good catch. But it's a question I have on the last, the line 30 of this amendment, where services to eligible recipients and their caregivers if the recipient's under the age of 19. So a question I have is, so we're dealing with minors here, if the recipient is a minor. And I'm sure there's a good reason for it, but I can't recall what it is. Why will we provide? It includes housing supports. As a general rule, parents do not rely on their minor children for, help paying the rent or the mortgage or whatever. Why is housing supports included there? Am I just looking beyond?
So,
What it
Chairman
should be.
Perkle, if you could just give us 1 second. We've been working at rapid pace, and we just want to make sure we have our notes straight to give
Okay.
you a good answer.
So just as a follow-up as you're going, just to fill up some of the time, as it's very quiet here. I've never been a big fan of life insurance on, significant life insurance on minors, because most families don't rely on the minors for, other than, to take care of an immediate need if something bad would happen to the child. And I just didn't understand here with housing supports for the family. I understand outreach, education, I understand case management, but the housing I didn't fully understand.
You want to take it? Yeah, so Chairman Perkle, our apologies. We've been having amendments come at us at, record speed. So it just takes us a second to kind of come back to why we said, this makes sense. So if you look at the initial language in terms of going all the way through what you just said, housing, employment, et cetera, to the eligible recipients, by adding in and their caregivers, if the recipient is under that age, then we have the ability to fold in the cared for also.
So it's in essence, if I may, Madam Chair, it's in essence to add additional support for the caregiver.
For the caregiver while the minor, well, I guess
While
in this
they're
case,
undergoing
the minor,
treatment.
Right,
Right, thank
exactly.
And the context of this provision is a waiver, the DCH asking for a waiver in a particular kind of category of potential coverage additionally. So that will be determined at a different level, what kind of support might come with that waiver if it's approved.
And our apologies, we pretty much have almost everything memorized, but not amendments that come, as quickly as they're coming.
Okay, all right. Do I have a motion on all of the ones included in AM 332023? Okay, got a motion to pass. Second, okay. Any discussion on this amendment? Okay, everyone in favor of the passage of the 2023 amendment, all the ones included there, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. Now we're back to Representative Al's amendment. You want to restate them again? Sure. Okay.
So in the original version of the bill, line 420, at the end of that line, it says workforce. After the word workforce, to add including the availability of culturally and linguistically responsive services.
Second.
And then there's
Motion and a second?
And then the second part
everybody-
of just
wait a
adding
minute.
the, sorry.
We're going to do them individually.
Oh,
Okay,
okay.
any other discussion on that amendment? Okay, can you
Certainly.
repeat it one more time?
Certainly. After the word workforce, at the end of 420, it says including the availability of culturally and linguistically responsive services. So basically interpretation, language access.
So it means you don't have to have every language, but if you do have them, try to include them. Is it, I mean, it's not a requirement?
I believe this is a study of the workforce.
Workforce,
So
okay,
including
right, okay.
looking at that availability. So it's
Okay.
not a requirement, just part of the study.
Okay. All right, you ready for it? Okay, we've got a motion and a second. Everyone in favor, say aye. Aye. Anyone opposed, no. Okay, second one.
And then the second part of the amendment is on page 49 of the original bill, after line 1227. Line 1227 says number 4, ethnicity. After that, I'd like to amend for number 5 to be languages spoken. And again, this is an assessment of workforce
Okay.
skills. And then to renumber the following.
Second.
Okay, we've got a motion and a second. Any discussion? Everyone in favor, say aye. Aye. Anyone opposed, no. Okay, we got the ayes have it. Okay, is that it? Really? Okay. Does anybody have any other questions about the bill as a whole or anything that you did not get answered or you want to answer now or forever hold your peace or whatever they say? Okay, so we have somebody from the audience that wanted to speak. Melissa Kay? I hope this is not too long.
Oh, no, I will absolutely respect your time. Thank you, Madam Chair, and the members of the committee. And I'm really grateful to Representative Jones and Representative Oliver for making mental health and substance use, for making this a priority. I really appreciate it. So my name is Melissa. I'm in long-term recovery from substance use disorder and opioid dependence and mental health concerns. I'm also a peer. I work for Georgia Mental Health Consumer Network. I'm the advocacy coordinator for the Georgia Peer Policy Collective, and I work with the Behavioral Health Planning and Advisory Council. So I'm here to voice my support for 520. I'm really grateful. It's a great enhancement to HB 1013. There is one comment I wanted to make about, it's section 12 in lines 772 to 780. 772 to 780 in section 12, I'm sorry, section 12. Section 12, line 772 to 780.
772. Okay, we've got it.
Do you have it? Oh, we do.
This right here. This is the new one.
Oh, yeah, it's on this bill, 94452S.
You need 772.
No, it's not. I'm so sorry.
It's okay.
It's section 12, section 12, that's what it is.
The original bill.
The 9452, I'm so sorry. See, now this is taking way longer than, I didn't want to do that to you.
I want to help you out, so I'm
Thank
I
you.
don't want to keep you hanging.
So sorry, Madam Chair and everybody. Okay, so this was referring to, oh, I'm on new lines, let me see. I thought it was 772.
So you were probably at the original bill? So
Right.
if the section that you want is this section in the sub, it's a different version of the bill.
Right.
So is that what you
I'm
need?
so sorry.
About the affidavits being connected?
Yeah. Can I just say my comment about it?
Oh, sure.
And
Right
I
ahead.
mean, yeah. I'm so sorry. So, thank you. I just wanted to comment on that. It was related to the involuntary commitment where two people can have their affidavit attached to a person's permanent medical record. And I totally understand the intent behind that in the story of the sister and her brother and everything. And I have compassion for that. I do feel that maybe identifying parameters for how long it can stay with that person in their permanent medical record, or if like identifying that it's only for that one-time involuntary commitment and doesn't move forward with the person forever, because it's sort of like, in my opinion, as a peer and having that experience, could have a negative impact on treatment later on from another provider or from the same provider.
682 is where 682.
Thank you.
Right in that area. Page 27.
Thank you so much.
You're welcome.
Yeah. Page 4. Yeah, so it was just, I wanted to make that comment and possibly have something attached to it that, it identifies like a measurable time parameter, or that it's only used in this one instance of involuntary commitment.
Okay, that it?
Yep, that's it. And I just really appreciate all the hard work and representatives putting mental health and substance use as a priority in Georgia. I definitely appreciate that.
Well, I mean, we have to thank the late Speaker Ralston.
Speaker Ralston, right.
And the new speaker who's continued, and all the work that Representative Oliver and
thank you so much.
Representative Jones have done on this, and my committee now, and thank you for that. Have y'all discussed, how does this work on, the involuntary commitment following somebody and all?
It's a court pleading that is sealed because it has medical information in it. These kind of petitions are sealed in the court record. And as the court record, the part of the affidavit that gives facts that goes is for the purpose of the treating people that are evaluating whether the 1013 should be granted at the medical facility. Those records are not a permanent medical record. They're a court document that is a sealed document.
Oh, okay, so they don't follow the person.
No.
They would just be in that proceeding, sealed as a court document, and it would be like it didn't happen, or as far as the...
I think the court record would show that their guardianship may have been granted at a certain point. That's a court record, but it would not give the medical record or the affidavits as part of the court record. That's sealed part of the record under the procedures of the court.
Does that help answer what you would like? Okay, thank you for coming and participating and bringing that to us. Okay, I think our posture is, we have a motion and a second. 4 o'clock came really early this morning. Dog got up, and I got up too, thanks to the dog. Okay, we have a motion and a second. Do we have any further discussion before we vote on this? From members of the committee. Is there anybody else from the audience that wants to speak on it? No. Okay, seeing none, everyone in favor of, if I got the right one, LC 339452S as amended, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Thank you to my committee for sticking with us, for being here as a and for getting this bill out.
Thank you, thank you.